Hi, everybody. It's Dr. Rebecca Griffith, the ED-DPT. Welcome back to another session of Admitted or Not, the ED-DPT podcast. And I'm really happy to have with me today Dr. Scott Capozza. Welcome. Do you want to introduce yourself?
Sure. First of all, thanks for the promotion there. I never did get my DPT.
Oh,
I'm old. I got my master's and I never made that jump to get my DPT. But I appreciate the promotion there.
well, yeah, you can have it honorary from me.
There we go. Awesome. Um, so I'm a physical therapist. I'm in Connecticut. Um, I started my career, interestingly enough, in pediatrics, but over the last couple of years, I've made this mid-career shift, and now I am an oncology physical therapist, and I'm part of the first cohort that got board certified in oncology physical therapy back in 2019. And I work in the outpatient setting. I've really built up our hospital oncology rehab program. But I'm really excited to be here with you today, Rebecca.
Well, thank you for being here. And so you're not an emergency department PT.
No, I am it's interesting. I'm placed in your traditional outpatient PT clinics. So my colleagues are treating folks with low back pain or after an ACL reconstruction, but I'm there treating folks throughout the cancer care trajectory.
I imagine that carries with it some emergency components, right? Because that's a pretty medically fragile group of folks.
Yeah, it can be, and that's something that I explain to the patient, or not just the patients, but to students whenever I have students, is to say that, yeah, this is a little bit more of a medically complex population. So we have to be mindful of, so many different things as far as, we should be doing vitals, and
Mhm.
we should be assessing for any change in status, whether that's mental status or balance or anything like that. Any new onset of pain, these are all things that we need to be cognizant of, especially, if we're working with somebody who maybe is on maintenance therapy or maybe has completed active therapy, and so they're not actively seeing their oncology team on a regular basis. Maybe those visits are more spread out, but we're seeing them, weekly.
Hmm.
We might be the first ones to identify something, and then we have to run that over to the oncology team to say, hey, I think something's going on here. I think, we need to investigate this further.
Well, who better than a physical therapist to be monitoring for that functional change?
Yeah. I'll give you a perfect example just to start off our conversation today. I was working with a gentleman who had metastatic prostate cancer, and just the sweetest guy you ever would have met. And he came to therapy all the time because he always said, I wanted to get stronger. And he would work hard. And and he actually had said that he stopped his chemotherapy because it was a quality of life concern.
Hmm.
He was losing weight. He didn't have his appetite, and so he was off active treatment for several months, and he actually did pretty well. And then he came in one day and he said, I've got this pain in my hip. And I said, oh. I said, well, did you fall? Did you do anything different? Did you sleep on it different? And no, I didn't fall. No, I didn't sleep on it different. And so that that was kind of a red flag for me. So I had to alert our oncology team, and unfortunately, he did have a metastatic recurrence, and it occurred in his femur.
No.
So, but yes, you're right. We have to be asking those questions because, like you said, we're on the front line working with these patients, and so if something like that comes up, we have to be able to clearly and quickly communicate that to the oncology team.
Well, for sure, to make sure they get the care that they need.
Yes.
So I have several questions for you, and I appreciate you being here today so that you can help those of us who do work in the emergency department be a little bit better in the care of our patients on that oncological spectrum. So I'm going to ask you some questions, and hopefully you'll have some like good tips for us. Does that sound good?
I'll do what I can.
Okay. So first of all, if we have a patient who is active, has active cancer, and they might be there for like, say, like just pain, like they're really there for like uncontrolled pain. is there a role for physical therapists in the emergency department to help with that? Or is that like really just need to be a medication related intervention?
Yeah, no, that's a fabulous question because first and foremost, you want to know where is the pain. So is the pain in their hip or their leg? Is the pain in their shoulder or their rib cage? So if the pain is in the leg, then yeah, we could be the ones who say, yeah, this person maybe needs some sort of assisted device to unweight that that leg in order to help them get around a little bit easier, right? So absolutely, right there in the ED, like you can be prescribing some sort of assisted device to help them out to relieve their pain. Before we started recording, you talked about how sometimes you do a lot of postural education, which I think again is great. And to dovetail with that, the idea of diaphragmatic breathing, I don't think gets enough press, right? So
No,
to
that's
be
a
able,
great point.
yeah, so to be able to get somebody to lie down and focus on their breathing, or to have them in sitting, and to really focus on their diaphragmatic breathing, right? And we know the benefits of, slowing down the breathing to be able to really focus on your breathing. It lowers your blood pressure, lowers your stress, and maybe that helps lower their pain. So right there, but people don't know how to breathe.
No, I think that's such a good point. And I'm shaking my head because I always have patients who come in acute pain, and they could be screaming, they could be writhing in pain, they could be yelling, they could be like lashing out. Like none of that freaks me out. And I can help that patient calm down, regulate their nervous system, and get to the point where they can be receptive to what's going to come next. And it just absolutely never occurred to me to try that with a patient who was there for like an acute cancer related pain issue.
Yeah, absolutely. And then the other scenario where I could see that happening, for example, for somebody who's actively getting oncology treatment, I think of the patients that I work with who have had breast cancer and they have the tissue expanders put in following mastectomy surgery. And depending on where you are in the country and depending on who your surgeons are and what their technique is, they may put that expander, which is basically like a plastic balloon, they may put it on top of the pec, or they might put it under the pec. And even if it's on top of the pec, the skin is still going to get stretched out, and that's going to be painful. If your plastic surgery team puts it under the pec, obviously there's even more pain that's going to be associated with that, because now you're moving the actual pec muscle at the same time. And so these patients experience a high level of pain, and it's almost like a roller coaster, right? They will feel okay, and then they get a new fill. They will inject saline into the expander to create this pocket for the permanent implant. So then they're in pain again. And so it's up and down. And so a patient might come in and they're in the active process of these tissue expander fills. So they're going to be in pain. And so again, we can't undersell, and I know there are so many different discussions online. I know you've seen them too. Manual therapy doesn't work. Manual therapy doesn't
works for me.
There's something to be said for the power of the human touch.
I agree. The way I explain that to my kids is, if you bump your elbow, what's the first thing you do? You touch it.
Yeah.
And I also find, just maybe this is just anecdotal to the emergency department, but so many of my patients have no one who ever touches them. And so they are kind of losing that therapeutic touch. And I'll hear from patients like, none of my healthcare providers ever touch me. And I'm like, what data are we missing? And what therapeutic alliance are we missing? So I touch almost all of my patients, even if I'm like holding a hand, and obviously you have to read the room, but like most of my patients actually really verbalize a lot of appreciation to that. So I find manual therapy for patients who are in acute pain can be very successful. But do you feel like it's okay to use that with this population?
Oh, yes, absolutely. I mean, the only time that you wouldn't do any manual therapy is if they have some sort of active open wound. So obviously you don't want to be right over that. But again, for that specific population, to be able to, and that goes again with your point earlier about posture, right? To think about posture, breathing, a little bit of manual work to try to relax that shoulder, to relax that upper quadrant. All that's going to decrease their stress, which could therefore decrease their pain.
Yeah, I can imagine that when they have like new onset of acute pain, even if they just have a history of cancer, that's probably pretty frightening.
And that's an excellent point, Rebecca, because this is one of the unique populations where, I mean, let's say what it is. Like, you're for better or worse, your body turns on itself. And so patients will kind of lose faith in their own body.
Yikes.
And so, yes, any pain, any discomfort, anything that happens down the road, it could be 6 months or 6 years later, it's going to be in the back of their head, did the cancer come back? And so part of that too is that education about being able to kind of, ask those questions, leading questions. Well, did you fall? Did you bump into something? Yeah, did your kid headbutt you or something like that? To be able to like try to tease all of that out. But yes, patients who've had a history of cancer are very hypervigilant if they experience any new ache or pain anywhere down the road.
I feel like I would be, for sure. So the other thing that I noticed with this patient population is increased risk of falls. Can you kind of speak to like what we should be looking out for with these patients? Because I feel like it's multifactorial, right?
It is multifactorial. And yes, that is such a huge thing that PTs can identify risk of falls and be able to do something about it, especially for you in the ED. You can address it right then and there.
Because that's why they're coming in too, many times. I can't feel my feet. I fell on my face, or I stood up too fast after chemo and I hit my head, or I got disoriented in the night, or I vomited until I was dehydrated and now I can't stand up. So what are the things that we should definitely be checking?
So yeah, so one of the big questions you want to ask is, how is the sensation in your feet? Because there are certain chemotherapy drugs that will cause chemotherapy-induced peripheral neuropathy. And unfortunately, there's nothing that we can do that from our interventions that can take that away. But again, we can make them safer. And in the ED, you can do some very simple screening tests, right? A 5-time sit to stand or a 30-second sit to stand, a tug, maybe a tug with the cognitive piece, right? You don't need any equipment, but you can do that and you can screen. And if that person is not looking great on those 2 quick assessments, then you say, oh yeah, this patient's at an increased risk for falls, so I should probably think about some sort of assistive device. And then again, ask those questions like, what's your home look like? Are there throw rugs? Do you have grab bars in the bathroom? Like, the education piece is so important, for those folks. Again, to your point, are you alone? Who's in the house with you, right? So who can help you, to make sure that you're getting up and down, who's anybody spotting you, right, as you're going up and down the stairs. So I think that's something that I would say, and that's what I do in outpatient, is awareness. Know where you are. And I always start with static balance, progressing to dynamic balance, progressing to cognitive challenges, all of those things, because those can all be a part of an increased risk of falls for patients with cancer.
For sure. I feel like they also have a tendency to feel like they just accept it as this like new normal, but it doesn't have to be that way, right? Like I can confidently say, hey, no, like you don't have to live like this. We can help with that.
Yeah. Again, neuropathy is definitely one of the more maddening side effects of cancer treatment, because there's not a great way to actually treat that. Even the oncologists don't have a fantastic way of treating that. But again, from a functional standpoint, from a mobility standpoint, we can, if you see them first in the ED and you screen them and you say, oh yeah, like this person's an increased risk for falls, then you can send them to, to someone like myself, and then you say, and I can read your note, and I can see that you screen this person, and yeah, they didn't do great on their tug, and they didn't do great on their sit to stand test. Okay, great. Then I know where I'm going, right? And
Ready
I
to
know
go.
how to take the ball from you and how to roll with it, to work on all of those static balance activities, dynamic balance activities, throwing in the cognitive piece, throwing in vision, all of that.
I love that. And I would say I don't do the tug a lot because honestly, there's not really an unimpeded walkway in which to do that, usually in the
Mhm.
emergency department. 5 times sit to stand I use very frequently because I can do it in the room. There's almost always a chair and a clock, and it's like no
Mhm.
issue. But trying to find a hallway where you're like not going to be in the way. The other issue is it's so distracting for
Mhm.
patients because there's gurneys going by and there's people yelling and there's people grabbing things and somebody is like bustling past you. And so I never know if my results are really even any good if
Mhm.
I do manage to find a quiet place for them to do that. So that's when I have a tendency to kind of skip. Sometimes if I can find a quiet place, we in some of the like observation parts of the emergency department, I'll try doing a DGI, and
Mhm.
sometimes that can give me a little bit more information. But one
Yeah.
thing I do with patients is I do the stops walking while talking test.
Okay.
If I can get you walking in the hallway, can you talk to me and attend to everything else that's going around here? Or do you completely stop and turn and look at me to have this conversation? Like, can you do both of those things at the same time?
Mhm.
And it's definitely like a quick way to see how they're functioning. And I'll have patients say, like, well, you're just so chatty. And I'm like, well, I'm just trying to see if you can carry on a conversation with me while we're walking. And they're like, oh, I drop my pen a lot too. And have
Mhm.
patients pick that up for me. Nobody appreciates that, but it's so automatic that people will just like bend right over and pick it up. And I'm like, that's what I need to see. Can you do that? And can you get back up without
Mhm.
falling forward? So those are some of the tools that I use for that. But I like that I can say, hey, like there are specialists who can help you rehabilitate from this.
Mhm. Yeah. And you're right. Everything that you just described there is all real world situations, right? Like
Hmm.
you're trying to cross the street, and there's cars going by. Like, are you safe to cross the street?
Yeah. And I think that's a when I used to work in spinal cord rehab, could you push your wheelchair across the street in enough time was something
Mhm.
we measured regularly. So I
Mhm.
think those tests help me figure out, can this person go home? Um, but one other issue that I have here is kind of that decision about should this patient with the active cancer treatment go to a rehab facility? Like, what are your feelings about that? Do you feel like, I mean, obviously, if they cannot function at home and there aren't any other options, that I may have to send them there, but like from an infection control perspective, from a like probable not having specialists being providing that rehab care, like what would you suggest for those patients?
Yeah. Again, I think I think there's a lot of questions that you want to ask, right? Like, again, does that person live by themselves, or do they have any kind of support? Even if somebody doesn't live with them, is there somebody that lives next door? Is there you know, an adult child or somebody that lives right next door or in the apartment below them or whatever, to be able to assist them with those kinds of things. Um, I mean, if somebody is really having a tough time, like, they're definitely a falls risk. Maybe there's a cognitive piece in there too. You know, maybe that's something to consider. But I would also, if you can, to be able to touch base with, those oncology providers and say,
Mm,
hey, you know, because they probably have, especially if they're in active treatment, those oncology providers, the medical oncologist, the radiation oncologist, the surgical oncologist, they probably have a little bit more of a background history as to where this patient is coming from and that sort
mhm.
of thing. So, you can collaborate with them and you kind of make that decision together as a team to be able to say, okay, yeah, this is, I know you're trying to take care of the cancer, right?
Mhm.
I'm trying to take care of this patient from a functional standpoint to make sure this patient is safe and is able to get back to independent living as best as that may be. So you collaborate together and you kind of maybe put your heads together to say, hey, what would be the most optimal situation for this patient? Is it short-term rehab and then with the goal of eventually following up with an outpatient, or or whatever that might be.
Okay, I like that. So if we have to, we have to.
If you have to, you have to. Yeah.
Yeah. Okay. That's helpful. So then when we're examining patients, so I see a lot of patients with musculoskeletal issues, obviously, who come into the emergency department for that type of thing. If this person has active cancer, what are like red flags for you that aren't necessarily like our traditional red flags for things that would like maybe warrant more imaging? Because your typical red flag questions aren't going to help guide that if we know the patient has cancer. So what do we need to be aware of with those patients? Like what is the best way to differentiate between like musculoskeletal pain from injury versus a musculoskeletal pain related to their cancer? Or how do we know if maybe we need to look, like you said, at potential for mets?
Yeah. No, that's a great question. And so I think there's a couple of things as you meet this patient and you are able to do a little bit of a chart review to see where they're at. I think of a patient that I'm seeing right now who she had a left partial mastectomy, and she had reconstruction, and her incision got infected.
Mm,
And so, the question right off the bat would be, pain, but then also to assess, do you have a fever, right?
yeah.
Right. And so, right there, those are two quick things to screen for. And if that patient does have a fever, okay, well, maybe there's some sort of active infection, which means, okay, we got to really run this up the chain and get this patient started with some sort of antibiotics or something. I think also when it comes to assessing in the ED, like in the moment, one of the big things again would be, your vitals, and especially respiratory.
Mm,
There is a rare, but it can happen condition where if somebody does have active cancer, especially metastatic disease, if part of that metastatic disease breaks off and it goes to the lungs, almost like a pulmonary embolism.
mm,
So any, sudden onset of breathing difficulties, that's definitely a red flag, and
okay.
so that you know definitely needs to be addressed right off the bat.
What about like new skin wounds? Is that something I need to keep an eye out for?
Yeah, absolutely. Because again, you don't want those new skin wounds to get infected. So you're checking, to see if they have a fever. You're probably going to have their, check their blood work to see, what their blood work looks like. So again, you don't want to necessarily treat over an active wound as it is, but again, to be able to alert the nursing staff, know, hey, I think this person has, or this person showed me, that they have, some sort of active open wound, which needs to be addressed, needs to, get some dressing right then and there.
Because that's a thing that I find I'll have several patients with cancer kind of complain of, well, I have these new wounds on my arm and I don't know where they came from.
Mm.
And I don't like that. That makes me a little nervous.
Yeah, and there actually are dermatologists that specialize in oncology, and so ultimately I think those would be the ones who could look at that and see what's going on. But you're right, there are some chemotherapy agents, especially also for our folks who are in active radiation, that definitely causes skin changes, skin breakdown.
Mm,
So again, to know where that patient is in their treatment cycle, if they're in their fourth or fifth week of radiation therapy, yes, their skin is going to be irritated. And so education, you want to tell them, I don't want you doing any kind of shearing motion,
mm,
right? Again, if I think of our patients who have breast cancer and they're getting radiation, I don't want any rubbing of that upper arm against that chest wall. I don't want any kind of
okay.
shearing motion, which is going to, cause any damage, to that area.
That's good to know. I didn't even think about that.
Mhm.
But that's why we're doing this.
Right,
These are
right,
things I would
exactly.
never even think of. And then, do you find that your patients will describe their pain in a different way when it's cancer related pain versus not? Or do you feel like they're pretty similar?
I think they're pretty similar, and I actually think that they're pretty spot on as far
Okay.
as saying like where their pain is. Um, again, I have a patient right now that I'm seeing who she had a mastectomy on one side, but she did not opt for reconstruction.
Mhm.
So she's wearing a prosthetic bra. I think the bra is too heavy because she came into me last week and she said that she said her back hurt. And I said, okay, well, where? Like, where does your back hurt? Is it lower back? Is it one side? Is the other? She goes, it's like right in the middle, right along the bra line. And she said, I have so much tension in my shoulders. And so again, by these series of questions, I'm like, well, and what's the size of this bra? She's, oh, it's a 7. I'm like, oh, maybe it's a little big. Maybe you need to go back to the boutique to be able to get resized. And so right there to be able to, they'll be pretty concise, but then as PTs, we have to be able to ask those more pointed questions to try to get to exactly where that pain is and how we can address that.
So is it mechanical? Is it not mechanical?
Right.
Okay, that's really helpful. So then I think my last question is, for patients where we are part of the differential diagnosis process,
Mhm.
what do you hope we don't miss?
Again, I think what we don't want to miss is any sign of, kind of an active metastatic disease. Like I was telling you earlier about the gentleman that I saw who had metastatic prostate cancer, to know where different cancers can metastasize to, and some of them, like breast and like prostate, can metastasize to the bone. So if somebody is either in active treatment or it's been a few years since they've been treated, but they have that history, and again, with our differential diagnosis that we know how to do as PTs, to be able to see, okay, is this some sort of external injury, something that's going on, or is it something that's internal that really warrants further investigation?
Because
So,
I'm thinking about that patient that you talked about with the prostate cancer, and if he didn't have that history of cancer or it was unknown,
mhm.
I wouldn't image that hip, probably.
Right, but I think right as if we're going through our differential diagnosis, we try, all of our hip strengthening and, do some gait assessments and kind of see where he's at. If it's one of those things where you've gone through all your whole list, right? You go
Mm-hmm.
through your whole list of, trying to do your assessment and nothing is really adding up, then
Mm-hmm.
trust your gut.
Okay.
I would say trust your gut and say, you know what? There's no harm in sending that in basket to the doc. Even if it's, even if they're, if they have not been diagnosed with cancer yet, to send a note to the, to the doctor who's in the ED with you, to send a message to the PCP, whoever that might be, to say, hey, I saw this person came in, they have hip pain. I went through my entire musculoskeletal assessment and, 2 and 2 is not equaling 4 right now.
Yeah.
So, I just want to make sure that I'm not missing anything. I think this patient, might warrant a little bit more of an investigation.
I love that. And there are times where we do discover new cancer in the emergency department. Do you have any tips on how we best address that with people?
We have to be careful what we say to patients,
Yeah.
especially if we're the ones that find it or we suspect it, because we don't definitively know. Like you will not definitively know until you get a imaging or you get a
Right.
biopsy. So it is a fine line to walk, because obviously you don't want to send people into panic by saying,
Right.
oh, I think you have cancer, because obviously there's so many emotions that are wrapped up with that. I think we as PTs can say, hey, I did my assessment, and you know, I'm still having some questions as to where this is coming from. I want to make sure that I don't leave any stone unturned. So I want to make sure that I'm going to collaborate with the other team members here. So again, for you in the ED, to be able to talk with the, with the docs that are there, with the nursing staff that's there, to say, hey, I just want to make sure that we're not missing anything here. I don't know what it is, but because I don't know what it is, I want to be able to provide the most comprehensive care for you.
That's helpful because Colorado, specific to Colorado, we can image here. We do have the ability to do that. And so I'm sure some of my outpatient colleagues are hearing you say that, because they do have situations where they will send a patient for an x-ray and it'll come back with like a sarcoma or something similar to that. And they need to know how to like best address that. So I like that kind of approach. Like, I'm not 100% sure what this is. We need to add in more team members to make sure that we get you taken care of.
Yeah. And I think the is, as doing that in a way that's not alarming to the patient, but again, presenting it to them to say, because that makes us look like we're team players, right? That we're not just, and I think you can agree with me, like, sometimes we as PTs, like, we can get stuck in our silos.
Oh, well, not in the emergency department. I feel like, luckily, that's one of my favorite things about it. But I think absolutely you're right.
Yeah. So good on you that, you do a lot of collaboration.
It's a team sport. It's contact sport.
It is a team sport. And so I think for all PTs to realize that, yeah, we cannot act in our silo. We can't just live in our silo. We've got to be able to reach out and to be able to collaborate, with other healthcare providers to provide the most comprehensive care for our patients.
Excellent. Okay, I've got one more question before we talk about the case. Because we always talk about the case at the end of these episodes. But my last question is kind of an awkward question. There are times where I am asked to come in and talk to families about rehab potential before they choose hospice. Whether that's on the acute care floors or sometimes in the emergency department, because sometimes home is not the discharge option and rehab's not the discharge option. And the discharge option that appears best is home with hospice care or inpatient hospice. How do you manage that with patients? Because I'm sure this has happened to you before, and I'm sure you've had a lot of loss in your career. How do we do this? I mean, I personally, it's like a whole nother soapbox and probably a whole nother episode, like, that I think physical therapists need to have a much bigger role in hospice care, because it's a privilege to walk somebody home. But what can I do? My favorite part about being a physical therapist is being a hope bringer. And this is one of those situations where I feel like people are feeling a little out of hope. What's the best approach?
Yeah. I don't know that there's a best approach, because I think it's all individualized.
Yeah.
Right? Like, that's one of the things that we do as PTs. We come up with individualized plans for that patient that's sitting in front of us, right? This is not a cookie cutter thing. Right. And so we have to, if we're at that point, like if we've been working with this patient or we've been called in and, we've been able to try to do a little bit of a review of this patient, we have to think about, what's best, for that patient. And then you're right. Like, what can we do to make them comfortable? And not just the patient, but also the family, the caregivers. What can we do? I mean, even if, we're talking about just like, bed transfers or, safety within the home or whatever that might be, right? Like, there's always an education piece that we can provide. And I also think this goes back to what we talked about a little bit earlier, which is human touch. Just to be able to hold somebody's hand and just say, I don't have all the answers, but I know that, I'm going to try to set you up to be as comfortable as possible for as long as possible. So again, if that's, things that you can order for the house for as far as positioning, to make the patient comfortable, to make sure that the family and the caregivers are, that they're safe, in taking care of their loved one. I think that those are all, things that we can contribute to that conversation.
I love that. What do you say if people ask you if they're going to walk again?
I say, I don't know,
That's
but
a great answer.
yeah, I say, I don't know about tomorrow, but I know you're sitting in front of me today. So today, let's see what we can do.
I love that. That's a perfect answer. Okay. Are you ready for the case?
I'll do my best.
Okay. So I'm going to tell you about a case I had where it was ostensibly a musculoskeletal back pain case. And I just want to like talk through it a little bit, and maybe you can tell me if there were things that I should have done differently. I think it turned out as well as it could have, and I'm going to change some details. But this was a patient who was an unhoused individual who came into the emergency department for back pain and difficulty getting up and down off the cots at the homeless shelter. And this person had only been unhoused for a few weeks. So it was a relatively new situation, had kind of lost everything. So the provider's kind of hypothesis was that they were just having trouble adjusting to like being on the cots, like pain, getting up and down, pain, like sleeping in that position. It was a lot colder, like so many different factors there. And the patient had also had some different gastrointestinal stuff, felt like she had gotten food poisoning. So really came in for dehydration, but also felt like that the back pain was an issue. And when we have individuals who are unhoused, we try to do as much as possible that we can for that patient while they're there, because we may be the only touch they have with the healthcare system or access that they have. So I was asked to kind of see if there was anything I could do for her low back pain. And my evaluation was frustrating because she was completely functionally independent and had intact strength and sensation, good reflexes. There was like, I pushed very hard. Like I did my PAs, and I did my unilateral PAs, and I did my quadrant testing, and I did my repeated movements, and I did my straight leg raise. Like I did all the things. And I couldn't really provoke her back pain. So to me, that was a red flag. Like I couldn't reproduce her back pain. And she described it just kind of as like a general aching and something that did wake her up at night, but not often. And she said she wasn't sure if it was the back pain or the other people in the room. And when I pushed on one of her spinous processes, she would have pain in her abdomen. And that felt weird. So I did an abdominal exam, and she didn't have any like really specific areas. Like couldn't really like localize it to a quadrant, but like it was uncomfortable. But she'd been vomiting for 3 days. I feel like my stomach probably wouldn't feel amazing either. And then she had on her upper shoulder a open wound that was non-healing. And she said, I think it's just not healing because I just pick at it all the time. But it's been there for a long time. So what would you like, what next steps, what would you look at here?
Yeah, so you're right. So you went through your whole musculoskeletal assessment and nothing really reproduced her pain, right?
No.
So like you said, that's a red flag. Like, if it's, a facet, or if it's, something else, like you're gonna be able to assess that.
I'll find it.
Right. So the fact that you don't have an answer after doing all of your assessment leads to, okay, well, what am I missing, or what else do we need to do that's maybe outside of, my actual hands-on assessment here? You throw in the GI. I don't know if the wound was, part of this or not, but you said, in Colorado where you live, you can order imaging. I would have ordered imaging if I was seeing that patient and I was living in Colorado like you are. I would have ordered imaging, because I would say this patient is reporting back pain, but I went through my entire musculoskeletal assessment and nothing was able to reproduce that. So something else is going on here.
So what kind of imaging would you have ordered?
I probably would have ordered some sort of, either lower spine, abdomen, assessment or X-rays, right, to see if anything was there, because I would have walked out of that room and I would have said, I don't have an answer, right?
Yeah.
And that's
Yes.
we can't do that. We can't walk out of that room without an answer,
Well,
because our patients deserve that.
Well, yeah, but in the emergency department, we whether we find the answer or not is not common, because the goal there, right, is, are you having an emergency or not? So I would say, but with, like I said, with unhoused individuals, we try to do a little bit more because they don't necessarily have that extra piece of follow-up. So what I did in that moment was I talked to her about sleep positioning on the cot. Like, what's a thing I can do right now to see if that makes any difference? And we also practice like getting up and down and things like that. And then I had the conversation with the physician, and through shared decision making, we decided a CT of her abdomen and pelvis, so we could kind of see many things at once. And I said, but I don't really think there's much else I can do for this patient because she doesn't seem to have mechanical low back pain. And then later that day, I got a second consult for this same patient, and I was like, "Are you kidding? Like, I told you there wasn't really anything I could do for this patient." But the CT had come back with metastatic peritoneal cancer, and the back pain was actually coming from a pathologic fracture of the lumbar spine. And I was being consulted for bracing of that fracture. And I asked the neurosurgeon, like, why is she not having that, like, mechanical pain? Like, why can I really push on that? And she's not really complaining of any pain. And he said, because those fractures have a tendency to just slowly crumble, and they often don't feel that pain until it completely collapses. And so that was a learning experience for me, that there could be something really wrong with the musculoskeletal aspect that maybe I was not picking up because it wasn't mechanically involved yet. And it turned out that the non-healing wound on her shoulder was actually melanoma. Mm. And that's where it had been coming from. Mm. So, as we say in the podcast episode, was the patient admitted or not? What do you think happened to this patient?
I would hope this patient was admitted, and they started some sort of treatment right away, and especially now that you've disclosed that she had the melanoma in her shoulder, was there any other involvement as far as like lymph nodes in the axilla? Were those involved? Like, does that need to get addressed? Hopefully she was started on some sort of systemic treatment right away. Yeah, so she was admitted and went on to get comprehensive care, so that, like, for me, it was subtle red flags. And when we're talking about, is this an emergency or not? She could have easily been discharged without seeing me. I mean, her primary complaint was nausea and vomiting. She got like medication for that. She had fluids. She was able to tolerate eating and drinking before she left. The back pain evaluation was like, let's see what we can do to just make this patient a little more comfortable and a little more functional given their current circumstances. But that feels to me like something that could have gone on being missed because her symptoms were not severe. And so that's the kind of thing the reason that I wanted to have this episode with you, so we could be a little bit more prepared to be on the lookout for those things and know how to manage them. So I really appreciate your being here today. Do you have any final thoughts to share? Final thought would be, I think when you and I went to PT school, Rebecca, we were taught that cancer in general was a red flag, right? Right. It's like, well, this person has cancer, like, don't touch them. Flag. Yes. Right. The whole thing, like just the diagnosis of cancer, the reddest of the red flags. Yes. Right. Don't touch them. Never. No. Don't do it. And so now, I think PTs need to be cognizant that we do need to touch them. We do need to be able to treat them. We are able to treat them. We are in a fabulous position to be able to work with folks with a history of cancer throughout their cancer care trajectory. And whether we see them in the ED, whether we see them in inpatient, whether we see them in outpatient, whether we see them in hospice. So there's always a role for physical therapy to be able to work with somebody with a history of cancer. because it's not what it was when we went to PT school. Just the diagnosis of cancer is not a red flag. That does not mean that there are not red flags within the diagnosis of cancer that we have to be cognizant of. Again, this kind of this kind of pain that we can't explain. So those are the things that we need to be mindful for. But absolutely, now we are highly qualified to be able to treat folks with a history of cancer.
I love that. And where should people go for more education on how to treat patients with cancer if they're interested?
So the Academy of Oncologic Physical Therapy is probably a great start, which is oncologypt.org. So that's the oncology section of APTA. So that's a great start. And then from there, there's I'm sure there's different social media outlets that you can follow. Again, APTA Oncology is on social media, as is APTA Oncology's Student New Professionals group.
Hmm.
So for any students and new grads, or even for somebody like myself who had a mid-career shift and needs
Same.
a little guidance, there is a very strong student new professional presence within APT Oncology, which is very, very supportive. So those are probably the two places that I would go to start for that.
Perfect. I appreciate your time and your expertise. Thank you so much for being here. And if you haven't liked and subscribed to our podcast yet, please do so. It's available on all of your major streaming platforms. Thank you.